Combination of mood stabilizers are the standard for treating bipolar disorder. Rather than having a simple regime of one mood stabilizer at high dose and a patient with side effects but who is not in remission, it now seems highly preferable to have a patient in remission without symptoms, no matter how many agents it takes. The doses of each agent can be lowered to tolerable levels, while the synergy among their therapeutic mechanisms provide more robust efficacy than single agents even in high doses. The best evidence-based combinations consist of addition of lithium or valproate to an atypical antipsychotic. Lithium, lamotrigine and valproate can be successfully combined in clinical practice due to practice-based evidence as shown below. Combinations of lamotrigine and valproate need to be carefully monitored due to interaction between the two, especially for the elevation of lamotrigine levels and the possible risk of serious rashes, unless the lamotrigine dose is decreased by up to half. Carbamazepine, although sedating, has less weight gain than many other agents and can be combined with lamotrigine despite relative lack of control studies. Attention should be given to the fact that carbamazepine is an inducer of CYP3A4, which generally means not combining with drugs that are substrates of the same, such as certain atypical antipsychotics including lurasidone, clozapine, quetiapine, aripiprazole and iloperidone. Lamictal combines the two agents with arguably the best evidence as monotherapies. Lamotrigine by itself is a stealth approach which is augmented by quetiapine, or with any other atypical antipsychotic, for example lurasidone for bipolar depression or depot long-acting risperidone injectable for rapid cycling. Other drugs as useful adjuncts include agents for substance abuse such as naltrexone, acamprosate and varenicline, agents for weight loss such as zonisamide and topiramate, and as previously discussed, agents for pain, anxiety and sleep such as gabapentin and pregabalin, and agitation such as benzodiazepine. And R-modafinil can be combined with atypical antipsychotics or lamotrigine in patients with bipolar depression insufficiently responsive of these agents alone. Boston Bipolar Bureau, named so by proponents who essentially never utilize an antidepressant for bipolar patients. It's any combination of mood stabilizers that does not include an antidepressant. California Careful Cocktail. More laid-back experts propose the possibility of patients earning the right to add an antidepressant, but carefully after exhausting other options. Thus, it's an addition of an antidepressant to one or more mood stabilizers, particularly including one or more that has robust efficacy against mania or recurrence of mania. Tennessee Moonshine. From experts there provide the option of treating bipolar depression that arises when giving an antidepressant and discovering that the patient either has activating side effects or treatment resistance, or the diagnosis is changing from unipolar to bipolar depression. In this case, rather than stopping the antidepressants, an atypical antipsychotic is added. Experimental and off-label combinations include combining lamotrigine with dopamine agonists such as pramipixole or ropinirole,